My name is Andrew Lasher. I'm the Chief Medical Officer of Aspire Health, and as Senator Frist mentioned, Brad and I are helping set up, basically think of it as a series all over the country of house call physician practices for really sick patients. That's how we talk about Aspire. What we're doing is, as you mentioned, is partnering with some of the best palliative care physicians in the country to provide a service that really hasn't existed up until this point in the private sector. My career in palliative care started, like a lot of people, in the intensive care unit, where I was noticing this just endless stampede of really, really sick patients who were clearly suffering, clearly at risk of coming in and out of the hospital, and often they were winding up in the hospital or the ICU as the very end stage of a terminal illness. When I started thinking about a career in palliative care, it was 2001, and it wasn't clear that there was going to be a career at the end of that rainbow. And it's a real credit to folks like Dr. Meyer, who's on this call, that the profession itself has grown to the extent that it has. But like most young palliative care providers then, I really had a choice between practicing in a hospital or practicing in a hospice. And as it turns out, I did both. But in the hospital, setting up inpatient palliative care programs in Northern California, I was actually with the Sutter Advanced Illness Management Program. You just began to realize that all these folks that we were seeing, these patients with cancer, with heart failure, with COPD, dementia, we were seeing them way too late. And you ask a palliative care provider, when is the ideal time to see a patient? It's clearly at the time of diagnosis, or at very least earlier in the course of an illness than what we were seeing in the hospital. And that's why I became so interested in programs that could see patients not at the point of crisis close to the end of life, but to see people earlier. So these patients where if you ask the question, would you be surprised if this patient passed away in the next year? People with cancers, heart failure, dementia, end-stage kidney disease, seeing them not in the hospital, but in the home setting or the outpatient clinic setting, when you can make a bigger intervention on their quality of life, their physical symptom management, emotional and spiritual symptom management, and potentially help break that cycle of hospitalizations so that people's care can really align with their values. So many people say they want to be at home as they get sicker, but so few people are. And what Brad and I are seeing is that if you can identify the right patient earlier in the course of their illness, intervene in the home, as we'll explain how we do, and provide that symptom management, that good care planning, that good care coordination, then people will feel better, they will live longer, and yes, they will cost less. And all of those things, I think, are very positive for the system, but more importantly, very positive for patients and families. And with that, I'll hand it back to Brad and let him walk through a little bit more of our model.
Thanks, Andrew. What Aspire, just as Andrew said, has really been focused on is helping stand up this group of palliative care practices and really doing all the things that you have to do to be able to take something like this to scale. What we saw across the country was really that the palliative care outpatient models that were out there, they were all really scattered and vastly underfunded. You saw lots of, especially nonprofit hospices that would launch these programs for a year or two on a grant, sort of understaff it, but have some services. The grant would go away, the program would go away. And so what we're really trying to build is sort of a scalable solution. So part of that, as we'll talk through, is about it being able to identify the right patients. What we know is if we offer this intervention for the right patients, it not only benefits them, but it also is a cost-effective solution for their health plan partner or their ACO. But we knew to build this, we really needed local market leadership. So we're going into each market across the country and recruiting the very best palliative care physician in that market to run these practices. And I think that the reason that we found those partnerships to be really strong is I think the palliative care physicians are looking for a partner who can help them set up a system to be successful. But for us, having these relationships in the market where they know the PCPs, they know the oncologists, they know the cardiologists is really important. And all the markets we're operating, we're investing in additional on-the-ground management capacity. We're building scalable systems like we'll talk about in EMR, clinical support system, policies and procedures. We're building quality metrics. We're actually integrating with the big national database for outpatient and some inpatient palliative care outcome metrics. And we're also proving that there's a good business case for palliative care by being able to take on financial risk and show the return on investment. So what is our model? What we do is we go out and we contract with anyone taking risk. In today's world, that's still primarily health plans, Medicare Advantage, Managed Medicaid, commercial health plans, but also at some provider groups, so ACOs, specialty physician practices. And then we have a number of ways that we partner with them to identify patients. We built algorithms that are specific to MA, Medicaid, duals, commercial. We are going out and doing physician meetings in markets. We built telephonic screens. We figured out ways to leverage other assessment and case management data that health plans have. But with each health plan or with each ACO, we figure out a way to identify patients who we think are likely in need of palliative care. In most cases, we work with their physicians, so their PCPs or their specialists, to make sure that palliative care is appropriate, and then we reach out to the patient. When we reach out to the patient, in most places, it starts with a nurse practitioner visit to the home. It's a comprehensive business. It looks at both clinical, psychosocial, emotional, spiritual needs, and then we're also running a number of outpatient palliative care clinics co-located in large oncology practices. Then we have a whole team that gets involved: nurses, social workers, physicians, nurse practitioners, chaplains that Andrew will talk a little bit more about. We provide 24/7 support, so when a patient calls us, they don't get a nurse triage line. They either get the nurse practitioner or the doctor in their market who's on call that night. And we found that, as Andrew will talk about, that 24/7 piece to be really important to providing high-quality care. And then we have a number of reports that we provide both back to the health plans and back to the PCPs and specialists. But with that, Andrew, do you want to talk a little bit more about the team?
Sure. As Brad alluded to, like any good palliative care intervention, it's an interdisciplinary effort where you're meeting on a weekly basis with a number of different roles, where everybody's responsibilities and roles are delineated, but their stewardship and the input are more shared. That's just sort of a standard feature of palliative medicine. I guess I would just tell a story. So this last week, we had the privilege of both onboarding a new physician in one of our markets in Tennessee, and also hosting this really amazing collection of physicians who are going to be helping us open markets all across the country. And these are people that did all the blocking and tackling to build palliative care as a field: Janet Bull and Martha Twaddle and David McGrew. That in our field, people who are quite well known. It's very humbling to work with. They're all in the office. So our physician in the morning was out with one of our nurse practitioners supervising and seeing how a visit goes. And what they found was a patient with advanced heart failure, very much in the throes of an acute exacerbation. The nurse practitioner had already addressed goals of care for this patient. The goals of care were really clear. It was survival above all else. This was a patient who was in their mid-60s, but had a late in life child who had not yet graduated from high school. Every effort was being made to get this patient better and prolong life with whatever means were necessary. So this involved the nurse practitioner placing an IV, giving intravenous Lasix, scheduling a follow-up visit the next day to check labs, just as you would in a hospital, treating an acute exacerbation of heart failure with all means necessary. And so she comes back to the office, and it turns out that there's a patient so similar in every way except the goals of care that our social worker in the office had developed a relationship with over the last 4 months. Prior to coming on our service, this had been a patient who'd been hospitalized, I believe, 4 times in the 3 months preceding. And now, because the hospice conversation, the goals of care conversation had been opened, this patient having an exacerbation was being transitioned into a program, hospice, where they were going to stay at home and focus exclusively on comfort. And because the barrier to that had been spiritual, an understanding of their responsibilities to stay alive that really weren't consistent with what the patient wanted, our chaplain had also become integral to their care. And our chaplain had gone to that patient's house late in the day to wait for the hospice nurse to be there to open the case. So 2 patients that were similar in every way according to their demographics, their claims data, but the goals of care were different. And I think what it illustrates is that you really need this interdisciplinary team that's responsive and, as Brad said, available 24/7 to respond to a patient or a family's needs, that is really how we try to provide our intervention that helps people stay out of the hospital when they don't either want or need to be there. And all of these roles are so critical for doing that. Brad?
Yeah, and so what we've built to support this team, both the team that's in the field and the team that's in the office, because the team in the field, I would say, acts very similar to a traditional home-based palliative care or in some ways sort of a hospice-ish team. The team in the office acts a lot more like a care management team. And so it's really the combination of these two things that we think is producing the outcomes that we'll share momentarily. But we've also built a couple different tools to support to all these clinicians. One is we've built some patient identification analytics where we can go out and work with health plans to identify the appropriate patients. The chart you see here, so month 0, this is month prior to death, so it's passing away on the right-hand side. This is from a real Medicare Advantage plan. The blue is the health plan's revenue per month, and the red is their cost per month. And so what you see is that to these health plans, the cost is significantly higher than what their revenue is every month. And these are just an example of the kind of analytics that we've built that both help health plans understand and see what their opportunity is, but also help us over time measure the impact that we're having. Another tool that we've built to support all the markets is we built our own EMR. It's focused on palliative care specific assessments, e-prescribing for controlled substance, tracking outcomes data, being able to share data back with health plans. But one of the most important things we do is this report on the right, which is a report that gets produced after every home visit. A big part of palliative care is you want to make sure that you're communicating back with the PCPs, back with the health plan, back with the specialist. And so we actually produce this report, and it goes back to all those parties after every home visit. In certain cases where we have large partnerships, we also build things like API, HL7 interfaces that can push the data directly back into EMRs. So how is this going? What do our outcomes look like? Here you see the enrollment rate. So when we have a patient referred to us, they're coming onto the service about 80-90% of the time. Compared to other care management programs, this number is really high. The reason we think we're seeing that is really the role of our lead physicians in the market. We're recruiting really great lead physicians. They're spending a lot of time building relationships with PCPs and oncologists. And when a patient isn't sure about if this is the right service for them, we're able to circle back with that PCP, maybe the nurse in their office, to reach out and talk with the patient. In terms of the diagnosis we're seeing, it really depends on what kind of health plan it is. This is for a Medicare Advantage plan. All of our patients, our average patient has 2.8 of these diagnoses, so this is sort of their primary diagnosis. But you see it's a range of CHF, COPD, cancer, dementia, end-stage renal disease, different populations. So say commercial health plans looks almost entirely alike, cancer with a little bit of neurological disease. We're doing, not surprisingly, a lot of advanced care planning. In addition to completing a lot of documents, which is what the graph on the left shows, there's a big JAMA study that came out in the spring that said the average advanced care plan gets completed 60 months or 5 years before someone passes away. So good to complete, but by itself we don't think that impactful. So the more important stat for us is the stat on the right, which is, are we engaging in active advanced care planning discussions with these patients at the time when they're likely to have a crisis, and making sure that their family, their PCPs, et cetera, are on the same page, so that while they might not have the crisis yet, they might just be likely to when the crisis does occur, when they call the 24/7 number, we can help their family and the patient deal with it in the way that they want to, just as Andrew shared with the example from last week. We're seeing really good outcomes data. So about 70% of our patients are getting discharged to hospice. A portion of them, 15% or so, die on the service. The ones who are passing away on the service are typically doing so because their goals are not yet aligned with hospice. And so they end up maybe going to the hospital. We've also had some patients that we've helped pass away at home, and that's been their goal. And they haven't wanted to go to hospice. And what we're seeing is when patients go to hospice, not only are more patients going, but they're also going earlier. So with the hospices we partnered, we more than doubled their median length of stay in the hospice, which both provides the patients more care and more support, and also has significant implications for the health plans. In terms of hospitalizations, we've seen a massive decrease with our intervention. This graph's a little confusing, but we've built an algorithm, and so this is data from one of our health plan partners. The middle bar is if you took every patient who hit the algorithm and said, what's their ADK? The left bar is if you took everybody who hit the algorithm and they were the patients who passed away. and on the right is where we are. We think the reality, because we not only use our algorithm, we use additional screens that are based on functional status and other things, it's probably somewhere between this 56 and 72%. But we think, and the health plans we're working with have confirmed, that we're dropping hospitalizations in this magnitude. And for example, the first health plan that we started working with less than 12 months ago has actually rolled us out into 8 new markets already. And so they're seeing really strong internal results. But the whole big part of making this happen and making this be successful has really been building the right team with the right expertise across a range of fields. So it's having leaders like Senator Frist, who are very involved at the policy level, but also people like Mike Tadine, who ran a large care management company called Inspiris that was purchased by United, and somebody like Matt Downs, who runs an investment fund of all the Blue Crosses across the country, but also having a strong corporate leadership team. Andrew came from Sutter, the Advanced Illness Management Program. Jay Ben used to run a health plan for United and also ran a large home health company. But the most important part of what we're doing is really the clinical leadership. And so we really have been extremely fortunate to recruit amazing clinicians like Martha Twaddles leading our practice in Illinois, David McGrew in Florida, Janet Bull. Martha and David were both presidents of the American Academy of Hospice and Palliative Medicine. Janet was the only site to win one of the CMI Round 2 innovation grants. And so we've just had these amazing clinicians. And I think what's really making it all click is having amazing clinicians with deep relationships on the ground, combined with really good systems and processes that can help those clinicians be successful in a scalable way, and in a way that can help guarantee and ensure the return on investment for the health plan so that they're willing to make the investment in these types of programs. And so with that, I will bring our presentation to a close, but thank you guys for letting us be a part of it.